A pleasant day to everyone. I hope you are all safe in your homes during this pandemic. Let us all continue to pray for the healthcare workers out there, the frontliners, and continue to pray for our country that we may get over this particular crisis. So, one of the lectures in cardiology, which is one of the most difficult, is this disorders of rhythm. So I urge you to just listen to this talk. If you agree with me, good. If not, better. Read on it and let's discuss next time, if there's an opportunity. This lecture is about heart rhythm disorders, and the science is still changing. If you look into your Harrison, this is 34 full pages of excruciating pain and unbearable suffering. So let's talk about something else. Let's talk about thunder. What is thunder? It's a loud rumbling or crashing noise heard after a lightning flash due to the expansion of rapidly heated air. Lightning is a sudden electrostatic discharge during a thunderstorm. It can also connote to describe something that's very quick, and somebody just took a perfect shot of the main building during this lightning strike. Very nice. Fire is the destructive burning of something. Perhaps the best way to describe the symptoms of arrhythmia is the one posted in the Heart Rhythm Society website. It is something that feels like thunder rumbling in your chest, maybe fish flopping in your chest, or drums pounding in your chest. Like lightning, it can strike without warning, leading to poor outcomes such as hospitalization, sudden cardiac death for patients who develop ventricular fibrillation, and a lot of morbidity and mortality. Fire can connote complications which can spread like wildfire, worsening of ischemic heart disease, heart failure. It can cause a stroke in patients who have atrial fibrillation, and a lot of complications due to intervention. What is a lumberjack? This is a person who fells trees, cuts them into logs, or transports them into a sawmill. Once upon a time, in a galaxy not so far away, it was the annual lumberjack competition, and the final was between an older, experienced lumberjack and a younger, stronger lumberjack. The rule of the competition was that the lumberjack who would cut the most trees would win the competition. And so the young lumberjack went straight away into the forest, chopping down trees, cutting down logs. He used all his energy and strength all throughout the day and all throughout the night. On his side of the forest, he was able to hear on the other side the old lumberjack also on his way to work. And what he heard was intervals of chops as well as breaks, like there were periods of chop, break, chop, 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 break, chop, 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 break. And so he was happy to know that maybe the old guy is taking a rest. And so he could use all his energy to continue cutting down trees, chopping down logs. And at the end of the day, he was proud of what he had accomplished. He looked at the number of logs that he had chopped and the number of trees that he had cut. But the whole story of heart rhythm disorders involves thunder, lightning, fire, the forest, lumberjacks, and many other things. Let's talk about these other things. So this is the outline of the talk. Of course, we'll try to review normal cardiac electrophysiology, take a look at the specific mechanisms of each arrhythmia, principles of diagnosis, and we'll focus on the clinical recognition and management of important arrhythmias in primary care, dealing with emergency management, and then followed by long-term management. It is important to know some of the basic principles, such as the physiology of the heart. We used to think that the heart is nothing but just a muscular organ, but you should not forget that the heart is also an electrical organ, a lot of intricate structures inside. In fact, as we speak, there is still a lot of science being learned on how the electrical mechanisms work. Great William Harvey even mentioned that he was tempted to think that the motion of the heart was only to be comprehended by God. But what we know today is that basically the electrical impulse starts from somewhere up there. The pacemaker of the heart, called the sinus node, travels down the normal conducting pathways, encounters a delay in the AV node before it travels down a bundle of His to the right and the left bundle branches, causing depolarization of the ventricle. So what happens is a very organized, systematic electrical stimulation starting from the upper chambers, which are the right atrium, and then the lower chambers. This is what contributes to the ECG rhythm of normal sinus rhythm, which very well you should know by now consists of a normal regular P wave followed by a QRS coming at a rate of 60 to 100 beats per minute at a regular rhythm. Any deviation from this sinus rhythm is called an arrhythmia. Basically, arrhythmias or disorders of rhythm are just disorders of the electrical system of the heart. They can present incidentally, such as an asymptomatic patient coming to you with an abnormal ECG finding. More often than not, they can come in with symptoms like palpitations, and once in a while, they can come to you with a fatal complication, such as syncope or worse, sudden cardiac death in patients coming in with ventricular tachycardia or ventricular fibrillation. What are the clinical features? They can mimic other medical diseases, but the common symptoms usually consist of palpitations, syncope. They can cause dyspnea in patients who have concomitant heart disease or even dizziness, chest discomfort causing worsening of your ischemic heart disease. A lot of these patients have a lot of anxiety. Arrhythmias can also cause secondary consequences in patients with heart disease. Bradycardia and tachycardia can cause worsening of heart failure as well as ischemia. In patients with atrial fibrillation, it can lead to thromboembolic complications such as stroke. And the most fatal scenario, of course, are patients who have ventricular arrhythmias that can present as sudden death. Usually, a complete history and physical examination is very vital. We ask for history of heart disease. For me, I usually take importance in asking for family history of sudden death, especially for young patients who come in with arrhythmia. A 12-lead ECG is vital. You get a 12-lead ECG both baseline during sinus rhythm and during the arrhythmia. Sometimes patients present infrequently, and so you need to take longer periods of ECG monitoring, such as your 24-hour Holter monitor, or in selected cases, a trans-telephonic event recorder, an implantable loop recorder. Exercise stress tests can also be used to evaluate for exercise-induced arrhythmia, as well as to screen for coronary artery disease. More often than not, we request for an echocardiogram to look at the ejection fraction, as well as underlying structural heart disease. Coronary evaluation is very important if you are considering coronary artery disease. Very rarely do you need what we call as an invasive electrophysiology studies, which is the most definitive test of the electrical system of the heart. These are pictures of some of the diagnostic tests consisting of your 12-lead ECG, your Holter monitor, ancillary procedures such as your echocardiogram, as well as exercise stress tests. An EP study is something that is done also similar, such as a coronary angiogram. It is done in the cath lab. You insert several catheters inside the heart under X-ray guidance. Along these structures, the catheters on their tips have electrodes capable of recording electrical activities, so you can get a more definitive, more comprehensive study of the electrical system, the conducting properties of the heart. Normal cardiac rhythm, of course, consists of integration of important mechanisms consisting of impulse formation, which relies on the proper an abnormality of impulse conduction, or a combination of the two. Usually, we classify arrhythmias into bradycardia, consisting of a heart rate of less than 60, and tachycardia with a heart rate of more than 100. The prototype for disorders of impulse formation for bradycardia is your sinus node dysfunction, otherwise known clinically as your sixth sinus syndrome. On the other hand, the prototype for disorders of impulse conduction is your heart block. For tachycardia, you have different mechanisms for impulse formation disorders. You have abnormal automaticity, triggered activity, and of course the most important mechanism for tachycardia is your reentry, this disorder of impulse conduction. Let's go to the juicy stuff. And I always say in medicine, physiology is king. I hope you still remember one of the lessons in physiology, the cardiac action potential. If you recall, the action potential starts with influx of sodium inside the cell, which brings the charge near threshold, and this incites an upstroke of the charge inside the cell, causing your phase zero depolarization. It encounters a delay in your let's go to the juicy stuff. And I always say in medicine, physiology is king. I hope you still remember this particular aspect or lesson in your physiology, the cardiac action potential. As we all know, it starts with phase zero, which consists of rapid sodium channels opening, allowing positively charged ions into the cell. Of course, the speed of depolarization determines the conduction velocity. Of course, let's go to the juicy stuff. And I always say, in medicine, physiology is king. I hope you still remember this particular lesson in your physiology, the cardiac action potential. It starts with rapid influx of sodium caused by our fast sodium channels that causes phase zero, causing the charge inside the cell to go to positive. This particular depolarization and repolarization is prolonged with closure. Oh shit. Let's go to the juicy stuff. And I always say in medicine, physiology is king. I hope you guys still remember this particular lesson in your physiology, the cardiac action potential. Of course, it starts with phase zero, which is the depolarization of the membrane caused by opening of fast sodium channels. Potassium flow also decreases. This is followed by phase 1, which is partial repolarization of the membrane due to a rapid decrease in sodium ion passage as the fast sodium channels close. Repolarization, of course, is halted with phase 2, the plateau phase, in which the movement of calcium ion channels caused by opening of the calcium channels out of the cell maintains this depolarization, this positive charge. This is followed by phase 3, your repolarization. Sodium and calcium channels close and the membrane potential returns to its baseline level. Phase 4 sees the membrane at its so-called resting potential of negative 90 millivolts due to the work of the sodium-potassium ion pump. Confusing, eh? Now let's get confused some more. Let's take a look at the general principles of arrhythmias. Bradycardia, of course, the prototype is depressed automaticity, and basically this is due to slowing or failure of phase 4 diastolic depolarization. If you recall your phase 4, this is the one wherein the charge inside the cell is negative. The cell is particularly in the confusing, eh? Let's get confused some more. Looking at the general mechanisms of arrhythmia, bradycardia and tachycardia, consisting of the abnormal impulse formation or abnormal impulse conduction. Let's start with bradycardia. Depressed automaticity is caused by slowing or failure of phase 4 diastolic depolarization. If you can recall, this is this particular phase in your action potential that is wherein the intracellular charge is negative. Uh, if you cause the failure of phase 4 diastolic depolarization and prolongation of this period here, of course, you obviously slow down the heart rate. On the other hand, increased automaticity, which causes tachyarrhythmia, is the other way around. This is caused by increased spontaneous phase 4 diastolic depolarization, and this is the one modulated by your autonomic nervous system as well as electrolyte levels. Shortening of your phase 4 diastolic depolarization, as you can see here, can cause tachycardia. These are several examples of clinical entities that cause abnormal automaticity. Any structure within your cardiac conduction system, whether in the atrium, both the right and the left atrium, in the ventricle, that has an automatic firing, can cause arrhythmia. And this is brought about by shortening of your phase 4 diastolic depolarization, either an increase in phase 4 slope or decrease in threshold for excitation. Triggered activity usually is due to what we call as leaky ion channels. This is caused by what are termed after depolarization. If you recall your action potential from phase 2 to phase 3, usually your calcium and your sodium channels should be closed. But if you have any mutation in particular cardiac ion channels, usually your calcium and your potassium channels, this can cause positive spikes in this particular phase here, caused by influx of this particular positive ions. Any accumulation of these positive spikes or positive charge inside the cell that can reach threshold can cause an arrhythmia, such as seen in this particular graph of the cardiac action potential. And this is the one that causes arrhythmia due to triggered activity. Re-entry is the most common and most important mechanism of arrhythmia. And this one I will need your full attention. For re-entry to occur, you need three particular conditions. You need two roughly parallel conducting pathways, labeled A and B, joined proximally and distally inside the cardiac structure. One pathway has different conducting properties compared to the other pathway, such that when the impulse comes in and encounters these two roughly conducting parallel pathways, it encounters A to be still refractory and cannot receive the particular electrical impulse. But B is capable of transmitting the impulse, so the impulse travels down towards B, towards the distal structure. By the time it reaches the distal structure, A is now no longer refractory, and in some way the impulse is capable of conducting back up retrogradely through A, forming the circuit. Repetition of this circuit can cause tachycardia. These are all examples of tachycardia. You can have what we call as AV nodal reentrant tachycardia, two pathways inside the AV node that can cause tachyarrhythmia. You can have an accessory pathway or a bypass track, an accessory connection between the atrium and the ventricle that is also capable of causing re-entry. You also have atrial flutter, which is a form of macro-reentrant atrial tachycardia. Of course, when you have a myocardial infarct that leads to a scar inside the ventricle, you actually have nidus for re-entry. You have a dead structure that is surrounded by These are examples of re-entry. You have AV nodal reentrant tachycardia, wherein you have two pathways inside the AV node that can cause supraventricular tachycardia. You can also have re-entry caused by an accessory pathway, normal connections between the atrium and the ventricle, causing atrioventricular reentrant tachycardia. Atrial flutter, of course, is a form of macro-reentrant atrial tachycardia. One of the particular important causes of re-entry is in a patient with myocardial infarct, wherein you have a scar, you have dead tissue inside the ventricular myocardium. Technically, you have tissue that is surrounded by conducting tissues joint proximally and distally. And this particular scar can be a nidus for reentry, and this is the one that's responsible for ventricular tachycardia that you see in patients with ischemic heart disease and myocardial infarction. So let's review. What are the three mechanisms of tachyarrhythmia? It's increase in automaticity, triggered activity, and of course the most important mechanism is your reentry. What are the two mechanisms of bradyarrhythmia? I hope you still remember. It's abnormal impulse formation caused by a decrease in automaticity and abnormal impulse conduction. Of course, the prototype of your abnormal impulse formation is your sinus node dysfunction, and the prototype for your abnormal impulse conduction is your heart block. Now, let's shift to a more interesting topic. When dealing with arrhythmias, these are the important issues to remember. First, you have to correctly identify the arrhythmia. If you cannot recognize the arrhythmia, you cannot treat the patient correctly. Is this patient symptomatic? Not all arrhythmias will present with symptoms. More importantly, you have to ask, is there any hemodynamic disturbance? Or is there any need to intervene? Some arrhythmias may be stable, and some do not need intervention. When do you not intervene? And of course, when do you seek expert consultation? And this is the empiric checklist for arrhythmia identification. And I need you to briefly take a look at this, review it, and know it by heart. Of course, the first thing to know when you're faced with arrhythmia is to check the heart rate. Is this rhythm fast or slow? Next question is to check the regularity. Is this rhythm regular or irregular? Third question, my most important question is there a P wave? Fourth question is each P wave followed by a QRS complex. Is the QRS complex narrow or wide? Are the intervals normal? Of course, the most important interval to measure is your PR interval. If you remember, what's the normal PR interval? It's 0.12 to 0.20 seconds. So roughly in an ECG strip, it should be not more than 5 small squares. And of course, ask yourself, is this rhythm dangerous or does this require treatment? So let's or normal. Next question. Is it irregular or irregular? Third question. Is there a P wave? Fourth question. Is each P wave followed by a QRS? Fifth question. Is the QRS complex narrow or wide? Then measure your intervals and so on. Let's review your ECG. Take a look at this first tracing. What do you see? Is it fast, slow, or normal? It's normal. Is there a P wave? Yes. Is it followed by a QRS? Yes. So what's the rhythm? Yeah, this is very easy. This is sinus rhythm. On the other hand, this next tracing, of course, shows a heart rate that is more than 100. It is fast. Is it regular or irregular? It's regular. Is there a P wave? Yes, each P wave is followed by a QRS complex, but the rate is more than 100, so this one is sinus tachycardia. Third tracing, of course, obviously, the rate is slow, rhythm is regular. There is still a P wave followed by a QRS complex, so what's this tracing? Sinus bradycardia. First tracing. Of course, I think that's the same tracing in the previous tracing. This is sinus bradycardia, but if you can take a look at the intervals, your PR interval is prolonged. It's obviously more than one big box. So this one is sinus bradycardia with first degree AV block. Take a look at the second tracing. Fast or slow? Slowing of the heart rate in the middle. Is it regular or irregular? It's irregular. Is there a P wave? Take a look at the P wave. PQRS, 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 and then there's P no longer followed by a QRS. What do you call that? That's a drop beat. And if you can see, there's progressive prolongation of the PR until you have a drop beat, and this one is second degree Mobitz 1 AV block. The third tracing, of course, you also see a drop beat in the middle. That's a P wave that is no longer followed by a QRS. But there is no progressive prolongation of the PR interval. The PR intervals are fixed, and somewhere along the way you just have a drop beat, and this one is called Mobitz type 2 second degree AV block. Of course, these next tracings are the important advanced AV blocks. You can see that the rhythm is regular, it's slow, there are P waves, there are QRS complexes, but they are not related to each other. So this is what we call as complete heart block. And to see it clearly here, you can see P waves as shown by the red arrows, and QRS complexes, the black arrows below. The P waves are not related to the QRS. The rhythm is slow, but it's regular. So this is complete heart block. Next tracing, first tracing, fast or slow? It's fast. Regular, irregular. It's regular. Do you see a P wave? Obviously, there's no P wave. The QRS is narrow, so this one is supraventricular tachycardia. Next tracing shows you an irregular fast rhythm. It's fast, irregular. Do you see P waves? There are no visible P waves. No visible P waves, irregularly irregular. This is your atrial fibrillation with rapid ventricular response. Now, these are all tracings that show you this bizarre looking QRS complexes, and these are your premature ventricular complexes. Look at those bizarre looking QRS complexes in between those normal sinus beats. Now, anytime you have 3 or more successive PVCs, that's already labeled as non-sustained ventricular tachycardia. Now, of course, a sustained ventricular tachycardia will present with this wide QRS tachycardia. There are no discernible P waves. What you see are wide QRS complexes occurring in succession, usually regular. This is your ventricular tachycardia. And of course, the most fatal arrhythmia is this tracing here, consisting of this chaotic undulations of the ECG baseline. And this is a must know for you. This is your ventricular fibrillation. Wow, we're done with the basic principles. Let's now go to the more exciting stuff. Universal clinical tip, which I need you to remember, especially when you go to the clinics, would be this one. You always approach any arrhythmia systematically in an organized manner, more so when it's an emergency. So I always say in any arrhythmia in an emergency setting, the first thing to do is to check the rhythm. And you can do that with your ECG. If there is a rhythm, the next thing you do is you check the pulse. By checking the pulse, you will be able to distinguish if your patient is arrested, in which he has no pulse, or your patient has a pulse. Of course, when your patient is arrested, no questions asked. You need to do CPR. If there is a pulse, what is the next thing to do? You have to check the blood pressure. By checking the blood pressure, you'll be able to differentiate if your patient is stable or unstable. If stable, then you can observe and monitor. If unstable, you need to give necessary treatment. Let's go to bradycardias. Bradycardias consist of either a failure of the impulse formation, exemplified by your sinus node dysfunction or sick sinus syndrome, or failure of impulse conduction, exemplified by your heart block. Now, of course, sometimes there are also what we call as benign bradyarrhythmias, or physiologic sinus bradycardia. You see this usually in athletes with high vagal tone. Sometimes patients, during sleep, it's normal for them to have sinus bradycardia. But anytime you have a sinus rate of less than 40 beats per minute in the awake state, in the absence of physical conditioning, then you need to work up this patient, and this is generally considered abnormal. Now, let's have some pretest questions. Sick sinus syndrome is usually a degenerative disease seen in elderly patients. True or false? Yes, that's true. Usually you see sick sinus syndrome in septuagenarians and octogenarians, and usually this is a degenerative disease. Number two, drugs may be a cause of sinus node dysfunction. Yes, that's very true. What particular drugs do you know that can cause sinus node dysfunction? You can have beta blockers, you can have your diltiazem, and several other antiarrhythmics can cause sinus node dysfunction. Permanent pacemaker implantation is the only reliable therapy for symptomatic bradycardia in the absence of extrinsic and reversible etiologies. Number three, that is true. In these patients, there is no medical treatment. You need to put in a permanent pacemaker. Number four, theophylline is the drug of choice for patients with tachycardia, bradycardia syndrome. That is false. Patients who have tachycardia, bradycardia syndrome also need a pacemaker. These are the causes of your sinus node dysfunction. Of course, the most common is your idiopathic degenerative disease. Sometimes it can be caused by coronary artery disease, and a lot of times by drug effects like your beta blockers, calcium channel blockers, your digoxin, and your antiarrhythmic drugs. I did mention earlier that excessive vagal tone can also cause sinus node dysfunction. If you look into your Harrison, there's a particular chapter there that lists down all the other causes of sinus node dysfunction, ranging from metabolic as well as electrolyte disorders and some of the other systemic miscellaneous disorders. Now, of course, the common clinical prototype of sinus node dysfunction is what we call a sixth sinus syndrome. These patients present with usually persistent bradycardia, spontaneous sinus bradycardia, or can have frequent sinus pause arrests, sinus arrests or pauses, or they can be a combination of your sinus and AV node dysfunction. Usually, also patients come to you with bradycardia, tachycardia syndrome. They can come to you with episodes of tachyarrhythmia, such as atrial fibrillation with rapid ventricular response, followed by a long pause, junctional rhythm, and tachycardia. So it's tachycardia, bradycardia, tachycardia syndrome. In rare instances, they can present to you with chronotropic incompetence. These patients usually come to you with easy fatigability. When you get their physical examination, the heart rate is between 50 to 60, otherwise normal. But when you let them run a treadmill, the heart rate does not go up. So there's chronotropic incompetence or impaired chronotropic response. And this is also part of the entity of sixth sinus syndrome. So, of course, the normal heart rate is 60 to 100 beats per minute. It should beat regularly at a rate of 60 to 100 beats per minute. Sixth sinus syndrome can present with just persistent bradycardia, or it can present with bradycardia, tachycardia episodes, or also called as your bradycardia, tachycardia syndrome. Clinical profile. Patients can present with syncope or pre-syncope. They can present with easy fatigability, angina or worsening of angina. Elderly patients can present with very subtle symptoms such as gastrointestinal distress or change in mental status. Patients who come in with tachycardia, bradycardia syndrome, of course those who present with atrial fibrillation, can present with embolic events such as a stroke. Sometimes they can be asymptomatic. Non-invasive methods are usually already enough to diagnose sixth sinus syndrome. You need a baseline ECG. In some patients, Holter monitoring or a transtelephonic monitoring to document the arrhythmias. Exercise tests might be necessary if you want to evaluate chronotropic incompetence. Very rarely do you need the invasive test called the electrophysiology study, because more often than not, you can diagnose this particular condition through non-invasive means. So what is the most important cause of death in sinus node dysfunction? It is thromboembolic complications. The cause of fatality is not usually the bradycardia. It is the complications brought about by your atrial fibrillation. That happens in patients with sixth sinus syndrome. So there's risk of embolization and an increased risk of stroke. Let's talk about heart block. Of course, heart block You know from your ECG knowledge that you classify heart block into first degree, which consists of a prolonged PR interval, second degree subclassified into Mobitz 1, Mobitz 2, and third degree or complete heart block. Of course, second degree Mobitz 1 and first degree AV block are usually benign, while Mobitz 2, second degree AV block, and third degree AV block are usually dangerous. Let's have a pretest. Idiopathic progressive fibrosis of the conduction system is the most common cause of complete heart block. True or false? That one is true. AV block caused by coronary artery disease may be transient or persistent. That one is also true, and that is why sometimes you can have a transient heart block in patients who come in with myocardial infarction. Number 3, Mobitz 2 AV block carries a worse prognosis than Mobitz 1 AV block. That is true. And number 4, in patients with symptomatic complete heart block, a permanent pacemaker is necessary. Yes, that is true. There's no medical treatment for symptomatic complete heart block. These are the causes of your AV block. Of course, the most common is still idiopathic fibrosis of the conducting system. But sometimes it can be caused by coronary artery disease or ischemic heart disease, presenting either as an acute myocardial infarct or patients who have chronic ischemic heart disease. Can also lead to heart block. And other drug effects like your digoxin, beta blockers, and your antiarrhythmic drugs, and several other miscellaneous causes like traumatic cardiac surgery, metabolic electrolyte problems, as well as a lot of inflammatory disorders. If you look into the natural history of your heart blocks, your first degree and second degree type 1, Mobitz type 1 AV block are usually benign, whereas your type 2 second degree AV block, as well as your complete heart block, these are the ones that are usually dangerous and requires treatment. Let's go to diagnostic techniques. Which of the following are common routine diagnostic tests in the evaluation of AV block? ECG? Yes. Holter? Yes. Exercise test? Yes. Electrophysiologic study? No. More often than not, you'll be able to diagnose heart block using non-invasive means. Very rarely do you need an electrophysiology study to diagnose this particular condition. Let's follow this universal algorithm in the management of bradycardia. As I always say, when you have a rhythm bradycardia, the first thing you do is to check the pulse. If the patient has no pulse and the patient is in cardiac arrest, then you need to do CPR. If there is a pulse, then you check the blood pressure. Checking the blood pressure, you'll be able to determine if the patient is stable or unstable. If stable, then you can give drugs. If unstable, you can give intervention, which is usually a pacemaker. Let's start off with a case. You have a 67-year-old, history of lightheadedness and syncope 2 months ago, currently asymptomatic, presenting with the following vital signs. What are you going to do? Yes, you have to get the ECG. Now, this is the ECG. What is the rhythm and what is the next best step? Give you 5 seconds to interpret the ECG. Of course, in this ECG, you see a P wave followed by a QRS regular, but the rate is less than 60. So what's the diagnosis? This one is sinus bradycardia. All right. So what's the next step? Do you do A, B, C, D, or E? What is the answer? Of course, in this particular patient, since the blood pressure is 120/70 and the patient is currently asymptomatic, the patient is relatively stable, and so you can just observe and monitor. Now, after several minutes, ECG converts to this particular tracing, and the BP is now 70 palpatory. The patient develops syncope. What is your management? Of course, in the ECG, you can see that the rhythm is also regular. It's very slow. There are P waves followed by QRS complexes, but they are not related to each other. And so this one is heart block. So how do you manage this patient? So for this particular condition, you can do A, B, C, or D. And this is part of your bradycardia algorithm. So for bradycardia, what do? You check the blood pressure sensorium. If the patient is stable, then you can observe. If unstable, then you follow this particular algorithm. I cannot make it any better. Just remember TAED. Okay, so transcutaneous pacing, if it's available. You can give your atropine push. You can give epinephrine infusion. Remember, epinephrine given for bradycardia is an infusion, not the push. Or you can give dopamine drip. So transcutaneous pacing, atropine, epinephrine drip, and dopamine drip, TAED. And then you refer to an expert for transvenous pacemaker insertion. So these are the principles of management for your bradycardia. You need to exclude reversible causes. Emergency management is usually just temporizing, and you can give an atropine push, epinephrine infusion, or a dopamine infusion. Some books recommend isoprenaline infusion if it's available. And of course, you need a temporary pacemaker in most of these cases, starting with transcutaneous pacemaker and followed by transvenous pacemaker. This is an example of your transcutaneous pacemaker. It's similar equipment such as to the defibrillator, but this time you attach a patch to the patient's chest, and it's capable of delivering an electrical impulse to stimulate the heart. More often than not, eventually these patients will need a transvenous pacemaker wherein you need to insert a central line, either the internal jugular vein, subclavian vein, or femoral vein, insert a catheter that's positioned with a tip position into the right ventricle, capable of delivering impulse and causing cardiac stimulation. Long-term management, of course, a permanent pacemaker is the mainstay of treatment for symptomatic bradycardia. This particular device is inserted in the pectoral area, and then there's a wire that is attached to either the atrium or the ventricle, and is capable of delivering electrical impulse to depolarize the heart. So what are the long-term principles of management of bradycardia? Symptomatic bradycardia, you don't need to treat. But when you have symptomatic bradycardia with irreversible cause, these patients will require a permanent pacemaker. Sometimes you need a combination of drugs, especially when you have patients who have sick sinus syndrome with bradycardia, tachycardia syndrome. You need drug treatment to control the ventricular response, and you need a pacemaker to prevent bradycardia. So these are the indications of your permanent pacemaker. Now the key word here is symptomatic bradycardia. So either a sick sinus syndrome, symptomatic sinus bradycardia, or symptomatic heart block. So let's review your bradycardia management. What is the acute treatment for bradycardia? Okay, so you have to remember your algorithm, your atropine, dopamine and epinephrine infusion, and your temporary pacing, so your TAED. Now, what is the long-term treatment for symptomatic bradycardia? Yes, so of course you have to exclude reversible cause, and you need a permanent pacemaker, especially for patients with sick sinus syndrome and permanent advanced heart block. Alright, so we're done with bradycardias. Let's talk about your fast rhythms, your tachyarrhythmias. So if you recall your ECG knowledge, your tachyarrhythmias, you divide them into narrow QRS tachycardia, wherein the QRS duration is less than 0.12 seconds, or a wide QRS tachycardia, with a QRS duration of more than 0.12 seconds. Technically, usually the narrow QRS tachycardia are your supraventricular tachyarrhythmias, while your wide QRS are your ventricular tachyarrhythmias. These are your different tachyarrhythmias. So you have sinus tachycardia, supraventricular tachycardia, atrial fibrillation, flutter, multifocal atrial tachycardia, and your atrial premature beats for your supraventricular tachyarrhythmias. On the other hand, your ventricular arrhythmias are your ventricular tachycardia, your ventricular fibrillation, and your benign ventricular premature beats. Clinical features, basically the same as your bradycardia. Evaluation and diagnosis, very much the same. So a complete history and physical examination is still important along with the other diagnostic techniques. Let's start off with a case. A 22-year-old female medical student consults because of palpitations. This happened after learning the number of exams she had to study for the next day. So your respiratory rate is 22. So what do you guys do? Of course, you have to get an ECG. Right. So this is the ECG of the patient. What is your diagnosis? So now you have a tachycardic rhythm. Obviously, this is more than 100. Is it regular or irregular? It is regular. Is there a P wave? Yes. Is it followed by a QRS complex? Yes. So what's the diagnosis here? So this one is sinus tachycardia. So the question is, how do you manage the patient? Is it A, B, C, or D? So for this particular tachyarrhythmia, there's no specific drug treatment. All are correct. No? You need to identify the cause, treat the underlying cause, check hemodynamics. Remember, sinus tachycardia is usually a physiologic rhythm. What are the management pearls? Normally, we don't treat sinus tachycardia with antiarrhythmics nor AV nodal blocking drugs. You treat the cause. Now, there are two exceptions to this particular principle. Ischemic heart disease, even if it's sinus tachycardia, you need to slow down the heart rate. You need to give this patient beta blocker because you need to improve coronary perfusion. You need to prolong diastole. Also, patients with thyrotoxicosis, even if they present with sinus tachycardia, you need to give propranolol to this patient. You need to bring down the heart rate. Otherwise, sinus tachycardia caused by other physiologic conditions, no specific treatment is necessary. What you do is you look for the cause and you treat the cause. Let's have another case. 33-year-old female bank teller, now coming in with palpitations and shortness of breath. What do? Of course, you have to get the vital signs. Blood pressure 120/80, 180 heart rate, 19 respiratory rate. So what do? Yes, you have to get an ECG. Now this is the ECG of the patient. What's the rhythm? What is your diagnosis? So what you have here is a regular, narrow complex tachycardia. Do you see a P wave? There is no P wave. The QRS is narrow. So the diagnosis is supraventricular tachycardia. This is your typical supraventricular tachycardia, usually coming with a sudden onset, regular, no discernible P waves because the P waves are buried within the QRS complex. This one is the most common paroxysmal regular tachycardia. These are the specific types of supraventricular tachycardia. 60% of cases, this is caused by abnormal pathways in your AV node, which you term AV nodal reentrant tachycardia. And of course, in 30% of cases, it can be caused by an accessory pathway. You call that orthodromic AV reentrant tachycardia. In 10% of cases, it can be an atrial tachycardia. And usually this tachycardias come suddenly, and so you're more often than not termed as paroxysmal supraventricular tachycardia. So AV node reentrant tachycardia and AV reentrant tachycardia, basically to simplify the pathophysiology, they are caused by an extra pathway. Let's have some fun, fast facts on supraventricular tachycardia. Is this true? SVT is due to coronary ischemia. Yes or no? No. SVT is not due to coronary ischemia. SVT is caused by acute coronary syndrome. Yes or no? No, it is not caused by an acute coronary syndrome. Third statement, SVT usually occurs in patients with severe structural heart disease. Yes or no? No. Usually it occurs in patients with no structural heart disease. That's why you can encounter SVT even in young, healthy patients. Fourth statement, it is a life-threatening disease and usually causes syncope and sudden death. That is wrong. It is not a life-threatening disease and does not usually cause syncope and sudden death. So these are the clinical pearls of SVT that I need you to remember. If you have a patient with supraventricular tachycardia in the emergency room, do not panic. Try to remain calm. Keep cool. Pretend to know what you are doing. Okay? Remember that this patient will not die from SVT. Okay? If stable, please get a 12-lead ECG. And more importantly, not all patients need to be admitted to the ICU. Always remember that. So pathophysiology of SVT is due to reentry. So as I mentioned earlier, you have two roughly parallel conducting pathways joined proximally and distally. Of course, when the impulse comes down, encounters a delay in one pathway, gets blocked, but is able to conduct down the other pathway. But the time it reaches the distal part, pathway A is no longer refractory, and the impulse is capable of conducting back up, completing one circuit. And so repetition of that circuit causes supraventricular tachycardia. And it's basically caused by the presence of an extra pathway. So for AV node reentry, it's due to the presence of a dual AV node, the slow and the fast pathway, while for AV reentry, it's due to the presence of an accessory pathway or a bypass tract. Basically, these are all extra electrical connections between the atrium and the ventricles, and they are invisible to the naked eye. So AV node reentry is caused by dual AV node physiology, slow and a fast pathway inside the AV node, while AV reentry is caused by the presence of accessory pathways, abnormal electrical connections between the atrium and the ventricles other than the AV node. This one is an example, very nice example of how supraventricular tachycardia occurs. So this one is a video of normal sinus rhythm. But then patients who have an SVT, say, have an extra pathway, like in this particular picture. So at some point in time, a particular impulse will capable be conducting back up that extra pathway, down the AV node, back up the extra pathway, completing this repetitive circuit, and this is the one that leads to supraventricular tachycardia. So that's why it comes with a sudden onset and sudden offset. It comes with a regular narrow complex tachycardia and no discernible P wave. So going back to the patient, this one is supraventricular tachycardia. How are you going to manage this patient? Do you cardiovert, defibrillate, give verapamil, or check hemodynamics? So in this particular condition, first thing to do is you have to check hemodynamics before you intervene. So the SVT algorithm is as follows. Check the blood pressure. If your patient is hypotensive and unstable, then you need to cardiovert. You start at 50 joules. First, you have to sedate the patient because cardioversion is very painful. If the patient is stable, then you can give medication. And so you can start off by remembering this particular acronym. If SVT VAC, that means you start with vagal maneuver. You do a carotid massage, 10 to 15 seconds on each carotid. It can be helpful in about 10 to 15% of cases. But you still do it while preparing for your adenosine. So you give adenosine. The dictum is you give 6 milligrams. If no response, you give 12 milligrams. If no response, you give another 12 milligrams. You have to give it by fast IV push. Follow it up with 20 cc NSS and raise the patient's arm. If there's no response to adenosine, then you can give a calcium channel blocker. And what we have is an IV verapamil, 2.5 milligram to 5 milligram. If still no response, then you cardiovert. Remember, before you give your verapamil, you have to check the blood pressure You cannot give verapamil if your patient is hypotensive. And at any rate, anytime your patient goes into hypotension, then you need to cardiovert this patient. So these are examples of the effect of adenosine on supraventricular tachycardia. It can terminate the tachycardia and bring back the patient to sinus rhythm. So this is the universal algorithm for your tachycardia. Hello? So this is the universal algorithm for your tachycardia. Of course, you start off with checking the pulse. If the patient has a pulse, then you check the blood pressure. By checking the blood pressure, you'll be able to differentiate if your patient is stable or unstable. If the patient is stable, then you can give your drugs. If the patient is unstable, then you do electrical therapy consisting of your cardioversion. So long-term management of your supraventricular tachycardia is done to prevent recurrences. You can do this by giving your patient or maintaining your patient on AV nodal blocking drugs. These are your beta blockers, calcium channel blockers, your diltiazem and verapamil, and your digitalis. One or a class 3 antiarrhythmic. What we have is your flecainide and your amiodarone. If still recurrent or the patient refuses medication, then you can do a radiofrequency catheter ablation as a curative therapy. So the definitive treatment of supraventricular tachycardia is to ablate one part of the circuit, and this is done by catheter ablation. You ablate the slow pathway, and in that way you cut off the circuit, you cure the patient, and the patient will no longer go into supraventricular tachycardia. So, of course, in all these particular causes of SVT, for AV nodal reentrant tachycardia, you ablate the slow pathway. For an accessory pathway, you ablate the accessory pathway. You cut off the circuit, and you no longer have recurrences of the supraventricular tachycardia. Let's go into this interesting ECG. What is your ECG diagnosis? I'll give you a moment to take a look. So as you can see, what you see here is a P wave followed by this YQRS complex and a T wave. But what is interesting though is that if you measure your PR interval in this particular tracing, it is shorter than 0.12. In fact, it is just 2 small squares, so that's equivalent to 0.08. So short PR interval. Normally, your normal QRS should have a P wave followed by a PR interval that is normally between 0.12 to 0.20 seconds. In that tracing on the right side, you have a short PR interval, and you seem to have this so-called slurring, upward slurring of your QRS complex. This is what we term as your delta wave. So this particular tracing is consistent with the diagnosis of pre-excitation or WPW Wolff-Parkinson-White ECG pattern. So it denotes also the presence of an accessory pathway that is capable of conducting the impulse antegrade. So what is WPW syndrome? Your ECG consists of a PR interval of less than 0.12 seconds, a YQRS complex duration, and a delta wave. Of course, what is the clinical significance? These patients can have supraventricular tachycardia. They can have atrial fibrillation with rapid ventricular response. And in worst cases, they can lead to sudden death or ventricular fibrillation. So what happens during pre-excitation syndrome? You have an accessory pathway capable of conducting the impulse antegradely. This accessory pathway does not have the slow conducting properties of the AV node. Hence, you have a short PR interval, and you have this delta wave, the slurring of the QRS complex. So this particular syndrome is associated with recurrences of supraventricular tachycardia. Sometimes WPW can come asymptomatically. You just have the ECG pattern, but you don't have any symptoms. We term that WPW ECG abnormality. Anytime you have the pattern plus the presence of paroxysmal SVTs and atrial fibrillation, you call it a syndrome. So WPW syndrome can present with supraventricular tachycardia, or they can present with rapid pre-excited AF. This particular AF is very ugly. It looks like this irregular wide complex tachycardia, also termed as your FBI, your fast broad irregular tachycardia. This particular tachycardia, you do not give your digoxin, verapamil, beta blockers, adenosine. What are the drug treatments of choice? You can give your procainamide if it's available. Amiodarone is not first line. In ideal cases, you need to cardiovert this patient, especially if they are unstable. So long-term treatment of WPW is similar to supraventricular tachycardia, but preferably a radiofrequency ablation is indicated for symptomatic patients. And you can give your pharmacologic therapy, your class 1 or your class 3 antiarrhythmics. We've been talking about radiofrequency catheter ablation. So this is a semi-invasive procedure which is done in the cath lab. You insert several catheters through the groin, position them into several parts of the heart, into the conducting properties of the heart. You're able to measure and study the electrical properties of the heart. And by doing so, this is an example of how it is done. For example, you have this particular accessory pathway there. You insert the ablation catheter in that area of the accessory pathway. You deliver a form of heat called radiofrequency. And this is the one that destroys the pathway, causing total cure. You remove one part of the circuit, and so you cure the tachycardia. The success rate for supraventricular tachycardia is quite high. It's about 96 to 98%. The recurrence rate, 2 to 3%, a very low complication rate. So it is quite preferred for recurrent supraventricular tachycardia or those who are refractory to medications. Right, let's have another case. 63-year-old male, hypertensive and diabetic, brought to you because of dyspnea. So what are you going to do? Okay, let's check the vital signs. Blood pressure 140/70, heart rate is 133, irregular, and respiratory rate is posted as such. So what's next? Yes, let's take an ECG. All right, this is the ECG of the patient. You can see it's irregular, narrow, complex tachycardia. There's no P wave. So what is the diagnosis? Now this one is a typical atrial fibrillation with rapid ventricular response. So how are you going to manage the patient? Do you cardiovert the patient? Defibrillate? Do nothing? Call the cardiologist. Please do not cardiovert this patient. Certainly you cannot defibrillate. Do not do nothing. So let us call the cardiologist. So anyway, atrial fibrillation is irregular rhythm characterized by ECG showing no discernible P waves. What you see are low amplitude chaotic fibrillatory waves, and it has an irregular RR interval. This one is the most common sustained cardiac arrhythmia, around about 1% of the general population. The incidence increasing in the elderly as well as in those who have structural heart disease. There are really a lot of factors or etiologies predisposing patients to AF, but basically anything that increases atrial pressure, and this includes your valvular heart disease, specifically your mitral valve disease, myocardial disease, heart failure, pulmonary hypertension, cardiomyopathies, any inflammatory atrial disease. Drugs, particularly alcohol, caffeine, sympathomimetics, may also play a role. Of course, you've encountered atrial fibrillation in endocrine disorders that are associated with increased sympathetic stimulation such as hyperthyroidism, your pheochromocytoma, of course changes in your autonomic tone, in your parasympathetic and sympathetic activity. Once in a while it's a pure electrical problem. You encounter this in relatively healthy patients with no structural heart disease. You call this idiopathic or lone atrial fibrillation. Pathophysiologic mechanism is a combination of increased automaticity in one of your pulmonary veins, as well as re-entry in the left atrial wall. But whatever the pathophysiology is, it causes a lot of clinically important adverse consequences. The shortening of the atrial refractory period would allow the atrial fibrillation to perpetuate and persist, and this leads to palpitations. Of course, when you have AF, you lose the atrial kick. That's literally about 20 to 25% of the cardiac output, and along with the structural changes such as dilatation of the atrial cavity, as well as fibrosis and histologic changes of the atrial wall, this leads to heart failure. Of course, the most important clinical consequence would be the stasis of the blood caused by prothrombotic changes, and this leads to an increased propensity for thromboembolic events, specifically stroke. Clinically, you need a good comprehensive history and physical examination. Of course, a baseline ECG. A transthoracic echo is always vital to look for structural heart disease, as well as to look at the left atrium. You need baseline tests of your thyroid and renal and hepatic function. Of course, we all remember some of the bedside physical signs of atrial fibrillation. You have a pulse deficit, wherein you have a discrepancy between your heart rate and your pulse rate, wherein the heart rate is higher than the pulse rate. You have an irregular pulse. When you check the jugular venous pressure waveform, because of the loss of the atrial contraction, there's no A wave in your JVP. On auscultation, there's a varying intensity of S1, as well as a varying amplitude of the pulse on palpation. Once in a while, you will need a transesophageal echocardiogram only for selected patients if you need to assess the presence of a left atrial appendage thrombus, because this particular structure cannot be seen on your transthoracic echo. Atrial fibrillation is classified according to its duration as paroxysmal if it self-terminates and it lasts less than 7 days, persistent if it lasts more than 7 days, and of course permanent, lasting for more than 1 year. There's increased risk of the following clinical complications. You have stroke, heart failure, and of course atrial fibrillation is associated with a higher mortality. There are 4 important aspects in the management of these patients. You want to target the etiology. You want to do rate control to control the ventricular rate, or in some cases you do rhythm control to prevent recurrences and convert the rhythm to sinus. Of course, most importantly, you need to prevent thromboembolic episodes. For the etiology, of course, these are the particular conditions that you need to treat. The heart failure, you need to control the hypertension, any possible electrolyte metabolic abnormalities, the presence of ischemia. Hyperthyroidism is a reversible cause that can be corrected. Of course, other medical problems such as infection or bleeding needs to be corrected, and you need to remove potential reversible causes. When you talk about rate control or rhythm control, basically these are done to relieve symptoms. And so there are 2 schools of thought. When you say rate control strategy, the objective is to control the ventricular rate and with no commitment to restore or maintain a sinus rhythm. And for this strategy, you just give drugs that control the rate. When you talk about rhythm control strategy, you want to convert the patient to sinus rhythm and keep the patient in sinus rhythm. This can be done either with both drugs, or you can convert electrically using DC cardioversion. Now, however, clinical trials show that there is no difference in mortality or stroke rate between patients assigned to rate control versus rhythm control. So let's take a look. Which are the drugs used for your rate control? Metoprolol? Yes. Verapamil? Yes, that's a non-dihydropyridine calcium channel blocker. Diltiazem, yes, of course. Digoxin, yes, it can be used, although it's not first line. Amlodipine, no. Amlodipine is a dihydropyridine calcium channel blocker. It has no effect on blocking the AV node. So these are the acute treatment for rate control. To control the ventricular rate, the first line is to give beta blockers. Of course, second line would be your verapamil or diltiazem. And you can also use digoxin, although this is uncommonly used as a standalone agent. Of course, in these patients, you need to anticoagulate if there are indications. And you give heparin or some of the other anticoagulants. If the treatment is rhythm control or cardioversion, there are two options. You can do pharmacologically with drugs, or you can do electrically using direct current cardioversion. Pharmacologic cardioversion, you can use the following drugs: amiodarone IV or oral, flecainide IV or oral. These are the ones available in our country. Now, when you're dealing with acute atrial fibrillation with severe symptoms and or an unstable hemodynamics such as hypotension, patient presenting with heart failure or ischemia, then the management should be DC cardioversion. This is a treatment of choice. It can convert your AF to sinus rhythm in more than 90% of cases. What you need is to deliver a 200 joules biphasic synchronized shock. And this is how you do synchronized cardioversion. No, this is not the way to do it. Please sedate the patient first. Do not sedate an awake patient. So long-term management, rhythm control consists of the following antiarrhythmics. Amiodarone or flecainide, the ones available in the Philippines. And for rate control, your choices are beta blockers or non-dihydropyridine calcium channel blockers, verapamil, diltiazem, digoxin, or a combination. Summary of your atrial fibrillation drugs. On the left side are your rhythm control agents, your class 1 and class 3 antiarrhythmic agents. For class 1, what we have is flecainide. For class 3, it's amiodarone. Where for your rate control agents, class 2 are your beta blockers. Class 4 are your non-dihydropyridine calcium channel blockers. Of course, digoxin is also a rate control drug. Take note that no antiarrhythmics have been proven to decrease mortality in atrial fibrillation. So factors to consider when you select the antiarrhythmics. Anytime you have heart disease, you cannot use your class 1 antiarrhythmics. These are contraindicated. And anytime you have heart failure, only amiodarone is recommended. For these particular two conditions, amiodarone may be an option. So let's have a review. Which of the following is used for rhythm control? Of course, it's flecainide. Okay, that's the class 1C antiarrhythmic. Which of the following drugs may be given for patients with structural heart disease? For this particular condition, of course, I just mentioned, your option is amiodarone. So going back to the case, what you have is an atrial fibrillation with rapid ventricular response. So what are we going to do? So the priority, to repeat, is rate control, not cardioversion. You can give beta blockers, calcium channel blockers, verapamil or diltiazem, and of course your digoxin. Now, unless you're sure that AF is acute, it's less than 48 hours duration, or you're dealing with AF with hemodynamic instability, for which case you can cardiovert pharmacologically, either IV amiodarone or electrical, using DC cardioversion. Do not forget to anticoagulate if no contraindications, and these patients need to be referred to an expert. Now, the fourth aspect of AF management is actually the most important, because atrial fibrillation, specifically non-valvular AF, is the most common cardiac disease associated with cerebral embolism, and it increases stroke risk 5-fold, with 1 of every 6 strokes that you see due to atrial fibrillation. The risk gets higher with the following risk factors: any previous history of stroke or TIA. Of course, mitral stenosis is itself a risk factor for stroke. The presence of hypertension, diabetes, old age, heart failure, as well as left atrial abnormalities. The choices for stroke prophylaxis can consist of antiplatelet, aspirin, clopidogrel, or anticoagulant warfarin. And of course, you have your newer novel anticoagulants in the form of the dabigatran, apixaban, rivaroxaban, which do not require INR monitoring. So this is a strategy for atrial fibrillation. Anytime you have valvular atrial fibrillation, specifically moderate to severe mitral stenosis, or the presence of prosthetic heart valves, no questions asked, these patients need warfarin. Give warfarin to maintain an INR of 2 to 3 for patients with mitral stenosis, or 2.5 to 3.5 for patients who have prosthetic heart valves. Now, when you have non-valvular AF, then this is the time you get your CHADS-VAS score. This CHADS-VAS score is a scoring system looking at the following risk factors: the presence of congestive heart failure, hypertension, age more than 75, diabetes, history of stroke or TIA, vascular disease, age between 65 to 74, and the sex category, giving the corresponding points. Take note that the higher CHADS-VAS score corresponds to a higher stroke risk. So if your CHADS-VAS score is 0, there's no need to treat. If the score is 1, it favors giving the patient anticoagulant, preferably a NOAC. If the score is 2, you must give an anticoagulant, preferably a NOAC, or if not possible, then warfarin. Then you also have to assess the bleeding risk, balance the benefit of the anticoagulation against the bleeding risk of the patient. Now, this is just to show you that there are other intervention procedures for atrial fibrillation. We can do catheter ablation of AF in indicated patients who have a very symptomatic debilitating disease. Surgical MACE procedure can be done in patients undergoing open heart surgery. And of course, in selected cases, you can do a left atrial appendage occlusion to decrease the risk of a thrombus dislodging and causing a stroke in case the patients have a contraindication for an anticoagulant. Just to summarize the treatment options in atrial fibrillation, of course, on the left side, your rate control and rhythm control. Basically, no proven morbidity and mortality benefit or advantage. But for stroke prevention, this is the one that has been proven to decrease mortality, hence recommended for majority of patients. True or false? Sinus rhythm is associated with a better survival compared to AF. Yes, this one is true. Antiarrhythmic medication to maintain sinus rhythm has been shown to improve survival in AF patients. Now, this one is false, right? Paroxysmal AF have less stroke risk compared to persistent or permanent AF. What do you think? False, okay? So regardless whether you're paroxysmal, persistent, or permanent, the stroke risk is the same, and these patients need anticoagulation. Patients with mitral stenosis and AF may be given aspirin to prevent stroke. This one is false, okay? So if you have mitral stenosis and AF, then you need to give these patients warfarin. All right, so we're done with your supraventricular tachyarrhythmias. Let's now go to the last part, which are your ventricular arrhythmias, your ventricular tachycardia, your ventricular fibrillation, or your benign ventricular premature beats. Let's start off with a case. 26-year-old anxious female, occasional palpitations, no comorbidities, previously healthy, exercises regularly, and a normal heart structure on echocardiogram. So this is the ECG. Obviously, on the ECG, you can see this bizarre-looking QRS complexes with no preceding P wave. So these are consistent with a premature ventricular complex. So the diagnosis is sinus rhythm with PVCs. So the question is this benign or malignant? So PVCs are common benign arrhythmias. They increase with age and the presence of heart disease. But there is no prognostic significance if your patients do not have any structural heart disease. So the dictum is if there are no symptoms, there's no need to treat. We do not treat the ECG. But anytime your patient has symptoms, but a normal echo, then you can treat symptomatically giving beta blockers, calcium channel blockers, as well as some of the other medications. Remember that there's no study proving that elimination of PVCs decreases risk or mortality. So the answer is this is benign. Let's have a case. Well, you are on duty in the ICU, but you're having your Big Mac and French fries dinner. The nurse calls you to refer a patient with a funny-looking ECG tracing on a cardiac monitor. So what do? Continue chomping on your Big Mac. Share some fries with the nurse. Ignore the nurse. Check on the patient. So this is a difficult task. You need to choose between the burger, the nurse, or the fries. Might as well check on the patient, right? So this is the ECG tracing. So what is your diagnosis? So what you have is a wide complex regular tachycardia with no discernible P wave. So this one is ventricular tachycardia, right? So what is the management? Do you cardiovert, defibrillate, give amiodarone, or check hemodynamics? All right. All right, so for this patient, remember, you have to check the vital signs, check the hemodynamics. So the first scenario is there is a pulse, the heart rate is 160 beats per minute, and the blood pressure is 120/80. So this one is stable ventricular tachycardia. So what is the management? Okay, for stable ventricular tachycardia, you can give your amiodarone. Second scenario, there is a pulse, the heart rate is 160 beats per minute, but now you have a BP that's palpatory 60. This one is unstable VTAC, but with pulse. What is the management? So for this particular condition, you cardiovert the patient, right? Synchronized cardioversion, remember to sedate the patient. Third scenario, there is no pulse, no BP. So this one is called pulseless ventricular tachycardia. So how do you manage this patient? This patient management is the same as ventricular fibrillation. So you need to defibrillate the patient and then do CPR. So this one is your VTAC algorithm, right? When you're facing with a ventricular tachycardia, you check the pulse. If there's a pulse, check the blood pressure. By checking the blood pressure, you'll be able to differentiate if you're dealing with stable or unstable VTAC. For stable, you can give your drugs. For unstable, you cardiovert the patient. Now, if there's no pulse, this is pulseless VTAC, patient is in cardiac arrest, defibrillate, and then do CPR. So your YQRS tachycardia, the algorithm is as follows. Check for the pulse. If pulseless VTAC, you treat as VF. Defibrillate and then do CPR. It's VTAC with pulse, check the blood pressure. Okay? If the patient is hypotensive, you cardiovert. If stable, you can give medications in the form of amiodarone. Now, anytime you have stable but persistent VTAC, do not wait anymore. Cardiovert the patient. Of course, remember to sedate your patient. Okay, let's have, I think this one is the last case. Okay, 40-year-old male, unconscious, zero vital signs. What do? All right, so please do not get a complete history and physical examination of this patient. So for this particular condition, you can call for a cold blue, perform CPR, and hook to a cardiac monitor all at the same time. So this is the cardiac monitor tracing. Now obviously, what is your diagnosis? What you have are chaotic undulations of the ECG baseline, no discernible true QRS complexes. So this one is ventricular fibrillation. So do you intubate, insert an IV line, do chest compression, or defibrillate? So for VFib, you do immediate defibrillation. Now in case you're still waiting for the defibrillator, do chest compression. Right? So ventricular tachycardia presents with a wide complex regular tachycardia. The top tracing is your monomorphic VTAC. The second tracing consists of different QRS morphology. So this one is polymorphic VTAC. Of course, the one tracing at the bottom is your ventricular fibrillation, presenting to you with chaotic undulations of the ECG baseline. So you have to defibrillate this patient immediately.
Charge. Stand by. Okay.
Okay, this one is not the way to do it. All right. So the pulseless arrest algorithm are the following: ventricular fibrillation, pulseless ventricular tachycardia on the left side, and asystole, pulseless electrical activity on the right side. When you say pulseless electrical activity, what you have is a bradycardic, usually a bradycardic rhythm, either junctional or idioventricular rhythm or any bradycardic rhythm, but you don't have a pulse. Okay, patient is still in cardiac arrest. The management is the same as asystole. So the ones on the left side are the ones you shock, VF and pulseless VTAC. So these are your shockable rhythms. The ones on the right side are non-shockable. You don't shock these rhythms. So let's go to VF and pulseless VTAC. Upon arrival, patient is in cardiac arrest, you do CPR. Upon arrival of the defibrillator, you confirm VF. Okay, you give immediate shock. Okay, you give 200 joules biphasic, 360 joules monophasic shock. Immediately, then do CPR. Immediately. 2 minutes, after 2 minutes, check the rhythm. If it's still VF, pulses to VTAC, give another shock, and immediately resume CPR. By this time, you can give your vasopressor in the form of epinephrine. 2 minutes CPR, recheck the rhythm. If it's still VTAC or pulses VTAC or VF, give another shock, and then resume CPR. By this time, you can consider giving your antiarrhythmic in the form of your amiodarone. So the dictum is shock, CPR, rhythm check, give another shock, CPR, rhythm check, give epinephrine, shock, CPR, rhythm check, epinephrine, then you can give your amiodarone, right? So remember, scream, okay? Please remember to do CPR immediately after every shock. For asystole and pulseless electrical activity, then there's no need to shock, okay? Upon arrival, you just do CPR, and then just give your epinephrine. Okay, so for this particular condition, of course, remember to check your reversible causes, your H's and your T's as listed down here. So these are potential etiologies that need to be corrected. Otherwise, you won't be able to resuscitate the patient. So tips and tricks for cardiac arrest: if your rhythm is either VF or asystole, no need to check the pulse anymore. Okay, just do CPR. In case it's VF, then you defibrillate. For VF and pulseless VTAC, remember your scream. If it's asystole or pulseless electrical activity, just do PE, right? Pump and then epinephrine. And of course, check for your reversible causes, H's and your T's. Some reminders, okay? So for defibrillation, you use 200 joules for biphasic defibrillator, 360 joules for monophasic defibrillator. If you're not sure, set to maximum. Always do chest compression immediately after defibrillation. Now, in case you don't have any amiodarone, the alternative is to give intravenous lidocaine. Of course, the causes of ventricular tachycardia are very important. Majority of these are still due to abnormal heart structure, predominantly coronary artery disease or a myocardial infarction, or heart failure, patients who have cardiomyopathies, either dilated or hypertrophic cardiomyopathies, along with other structural heart disease. Now, in minority of cases, in about 5%, it can happen in patients who have normal heart structure, and these are your electrical disorders, your ion channelopathies. You've heard of bangungot. Bangungot is actually an electrical disorder of the heart called Brugada syndrome. You have other channelopathies like long QT syndrome, idiopathic VF. This can happen, causing sudden death, even in young, healthy individuals. But of course, the majority of causes are still due to coronary artery disease and cardiomyopathies. For this, you use the ejection fraction, which is a risk marker for the risk for sudden cardiac death. Anytime you have an ejection fraction of less than 35% or a poor systolic function, these patients are at high risk for VTAC, VF, and sudden cardiac death. So for non-sustained VT, you assess the patient further. If it's sustained VT, then it's an emergency. You give the necessary treatment. So non-sustained VTAC, review clinical history, evaluate your left ventricular function, do a 2D echo, and you proceed accordingly. If it's an abnormal echo or a low ejection fraction, or a patient with heart failure, coronary artery disease, You try to treat the cause. If it's ischemia, okay, optimize your treatment for heart failure. These patients will need a beta blocker, and you may need to give amiodarone to prevent further recurrences of your ventricular tachycardia, especially if the patient is high risk or with structural heart disease. For sustained ventricular tachycardia, okay, acute management for stable would be the following. Of course, your first line is amiodarone intravenously. If unstable or persistent, then you do synchronized cardioversion. If pulseless, then you treat as the same as VFib or defibrillate. So ventricular fibrillation, of course, the acute management is immediate defibrillation, then CPR, right? Shock the patient, then do CPR. Then you can give your epinephrine, then later, according to the algorithm, you can give either amiodarone or lidocaine. So how do you differentiate defibrillation versus cardioversion? So when you talk about defibrillation, this is the use of a high voltage shock that is delivered immediately upon pressing the discharge. The shock delivered is timed with your QRS complex, and this is usually low voltage shock, and this is delivered concomitant with the QRS complex in order to avoid the relative refractory period, for which case it might precipitate a VF. Synchronized DC cardioversion is done for supraventricular tachycardia, stable VTAC, and sometimes your atrial fibrillation. So you have to know the difference between the two. Just to show you what happens during VFib, take a look. Immediately there's loss of the pumping action of the heart, and these patients go immediately into cardiac arrest. Now, the value of doing immediate defibrillation, as you see in the right video, there's immediate resumption of cardiac contraction when you defibrillate the patient. And that is why when you're dealing with ventricular fibrillation or witnessed arrest, early defibrillation is key for these patients. Okay, so in the ward, patient drops dead or witnessed arrest, someone should go run get a defibrillator. That's the only way you're going to save the patient. Now, while waiting for your defibrillator, do CPR. Okay, let's go back to your pulseless arrest or cardiac arrest rhythms. Okay, VFib, pulseless VTAC, asystole, pulseless electrical activity. So which rhythms do you shock? Okay, it's the ones on the left side. These are your shockable rhythms. The ones on the right side, you do not shock. So empirical approach to your ACLS, of course, you do compression, airway breathing, and then you do CPR. Okay. All at the same time, you give this patient oxygen. Okay, you hook to a cardiac monitor, and you insert an IV line. Okay. Just to emphasize to you, if it's in a hospital setting, you do not do mouth-to-mouth resuscitation. You ambubac the patient per mask until such time that you are able to intubate and back the patient per ET tube. Now, once the ECG arrives, your responsibility now is to identify the rhythm. So if it's VF, pulseless VTAC, then you do defibrillation and then do CPR. If it's asystole or pulseless electrical activity, then just do CPR. Now, you have to make sure that you're sure about your rhythm. Okay, do not take a long time analyzing the ECG. Okay, if there's any doubt, then just do CPR. If you're unsure if a pulse is present or absent, just do CPR. So once you have revived this patient, of course, you need to admit this patient and manage accordingly. Okay, so this is the in-hospital management, especially for patients who have structural heart disease, coronary artery disease, cardiomyopathy. You have to treat the cause. Optimize hemodynamics. These patients will be in the ICU. If there's low blood pressure, then you give vasopressors or inotropics. Maximize whatever medical therapy you can give for ischemia or heart failure. If the cause is acute MI, then revascularize accordingly if able. Antiarrhythmic may be given in the form of amiodarone, that's first line, or alternately lidocaine. and correct the correctables, your oxygenation status, acid-base balance, your electrolyte levels. Now, once the patient is stable, has survived, and has good chance of recovery, then you need to assess the patient for a need for an implantable cardioverter defibrillator. So this is a device inserted into patients who have survived and cardiac arrest, or who are at high risk for another sudden cardiac arrest. So it's similar to a pacemaker, slightly bigger. You insert it in the pectoral area. What it does is it monitors your heart rhythm, and anytime the patient goes into VFib or VTAC, delivers a shock. So this device treats sudden cardiac arrest. So what are your indications for ICD implantation? Patients who have resuscitated ventricular fibrillation, those who have heart disease, sustained ventricular tachycardia, myocardial infarction with low EF, plus moderate heart failure. So take note, even without any previous cardiac arrest, once you have the risk factors, low ejection fraction and heart failure, or dilated cardiomyopathy with heart failure, then you have an indication of ICD implantation to protect you from sudden cardiac arrest. How does a defib shock feel like? That's how it feels like, folks. Right? Okay, so I hope that wasn't too painful. Okay, I think in about 1.5 hours we were able to review the principles of electrophysiology, the different brady and tachyarrhythmias, your supra and ventricular tachycardias, and we were able to look at the different tracings of your ECG. So going back to the forest, arrhythmia is actually a forest. Sometimes we might be paying too much attention on the trees. We forget about the big picture. Or sometimes we're taking too much focus on the big picture. We forget about the specifics, the tree or the trees. If arrhythmia is the forest, then we are the lumberjacks. Let's go back to the two lumberjacks. By the time that the young lumberjack had finished, he was proud of what he had achieved. He looked at the number of trees he cut, the number of logs that he chopped, and he went proudly to the podium. And he was expecting really to win the lumberjack competition. Surprisingly, the old lumberjack also went up, and he was quite surprised to see the old lumberjack also full of stamina. When the verdict came, the young lumberjack was able to chop down 35 trees. But the old lumberjack was able to chop down 50 trees. And so the young lumberjack was surprised. He was devastated to hear that the old lumberjack had chopped down significantly more trees than he had. He asked, "How can this be? I heard you take a rest every hour, and I worked continuously through the night. What's more, I am stronger and fitter than you, old man." What did the old lumberjack say? "Every hour, I took a break to rest and sharpen the axe." So, ladies and gentlemen, when we're dealing with cardiac conditions such as arrhythmia, once in a while you need to sharpen the axe. Okay? You need to educate ourselves. The battle against arrhythmias and its consequences involves regular sharpening of the tools. You have to remember that not all arrhythmias are complex. Some are benign. Some may be dangerous and life-threatening. Remember your ECG recognition. Know your ACLS algorithms. Always correlate clinically and hemodynamically. Know your treatment options. Of course, the ultimate clinical pearl that I can give you today is to treat the patient, not the ECG. So to our lumberjacks in the profession of healing, you have just sharpened the axe. Thank you very much for your attention, and I hope you learned something new today.